We are live now, and with all your due permission, we are starting out today's session. A very good evening to one and all present here. I am Debolina from Learnit. We are very much proud to be a part of this webinar as a digital partner. Learnit is India's largest live digital CME and doctors-generated medical content platform, which is exclusively free for all the medical practitioners. So now with all of you, I am going to share a short glimpse of Learnit. Thank you so much all for your patience. You all are invited to visit our site, which is www.learnit.com. There we have lots of live sessions conducted by eminent speakers across the globe. We have MedWiki services, which is medical Wikipedia for doctors that you can read. Besides, we have Telemed site also that you can use. So now, without further delay, I would like to hand over the session to Dr. Aarti Heda ma'am to start with our today's scientific program. Over to you, ma'am.
Thank you so much, Debolina. So, good evening, everyone. I, Dr. Aarti Heda, welcome you all on behalf of Team Surfing the Anterior segment to this episode of Season 3 of Surfing the Anterior segment. So, Surfing the Anterior segment is a case and a video-based webinar series initiated by IOC in month of May 2020 with the aim of discussing and understanding the complexity of managing an ophthalmic case and providing fresh perspective to the approach. So subspecialties we covered included cataract, cornea, glaucoma, strabismus, and oculoplasty. So we did around 10 sessions in season 1 and 10 sessions in season 2 as well. Surfing the Anterior segment has been part of U Pavilion in AIOC 2021 and 2022. So with the same enthusiasm, we decided to continue this journey. So in this season, we decided to have it in the form of case presentations, debate, quiz, surginar, or a video-based session. So here we are in first episode of season 3, wherein we are going to discuss Aphakia in details. So let me remind our audience that you can ask your questions by unmuting yourself, or you can put them in the chat box and we shall take them towards the end of this session. So now I would like to invite Dr. Nandini Chanduk, who is a cataract and a refractive surgeon at AM Medical Center, BBI Foundation, Calcutta, who will be moderating the session with me. So over to you, Nandini.
Thank you, Aarti, for that lovely introduction. So we'll be doing a session today on aphakia. I would be inviting our first guest lecture by Dr. Harshal Tuck, who actually needs no introduction. But just to complete, sir is a very dear friend and is the director of Rawat Eye and Phaco Surgery Center at Jaipur Laser Vision Center and is also the member of ARC Central Zone AIOS. He is also the chairman scientific committee of Rajasthan Ophthalmic Society. So, sir, we would be having a pleasure of your talk today.
Thank you so much, Dr. Nandini, for that wonderful introduction. And thanks to Dr. Aarti, Dr. Karan, Dr. Divakant, Dr. Sonal, and entire team of IOC for having me here. So it's always good to be amongst the young brains and who are the future of Indian ophthalmology. So I'll be speaking about posterior capsule rupture. Can you see my screen?
Yes, sir.
Okay. Just a minute. Okay. So we all know that posterior capsule rupture is the most fearful complication, which not any surgeon wants to face this, but it can occur in the hands of experienced as well as in the hand of novice surgeon. So posterior capsule rupture is reported to occur in 0.5 to 7.5% of cases and is a significant potential complication of cataract surgery. Whereas if PCR is not properly managed, we can have adverse impact on the outcome of cataract surgery. And visual vitreous loss is the most crucial factor which determines the eventual visual outcome. And we all know that PCR with or without vitreous disturbance can lead to increased incidence of hyphema, increased persistent post-operative inflammation, retained cortex, corneal edema, post-operative endophthalmitis, CME, and tractional retinal detachment in long-standing cases. So let's look at some of the factors which influence PCR consequences. Firstly, the stage of the phaco at which it occurred or we recognize this PCR. The coexisting pathologies in the eye which are there. It depends on expertise of the operating surgeon, whether he's a skilled experienced surgeon or a novice surgeon, and facilities which are available with the surgeon to manage this case. And consequent vitreous loss is a major determinant of post-operative outcomes. So there are some patient-related risk factors for PCR, like some general factors. If patient is restless, anxious, elderly, obesity, or COPD, demented patients, or patients who have inadvertent head movements. So this increases the risk of posterior capsule rupture. There are extraocular factors like deep set eyes with prominent brow or exaggerated Bell's phenomena, because there's a lot of pooling, there's difficulty in visualization. So surgeons may get PCR more in these kind of cases. Some intraocular factors are there which increases the chances of PCR, like if patient has corneal opacities with visibility issues because of maybe dense pterygium or Fuchs endothelial, Fuchs dystrophy, or other corneal pathologies. So we need to take care of these things. There are certain types of cataract which we all know we should be careful, especially during the beginning of the career, that these cases, these type of cataract, they increases the potential for posterior capsule rupture, like intumescent cataracts, brunescent or black cataracts. Posterior polar cataract is the biggest risk factor, traumatic and post-vitrectomy cataract. Then pseudoexfoliation and small pupil because of eye phase or because of diabetic or any cause, it increases the chances of posterior capsule rupture. If there is shallow anterior chamber in hypermetropes, it increases the chances because there is increased risk of touching the posterior capsule because of the shallow anterior chamber. Or if there is deep anterior chamber in high myope patients, the posterior capsule, because of the trampolining effect, it may come towards the phacoprobe and can lead to posterior capsule rupture. Or LIDRS, we all know lens iris diaphragm retropulsion, again, is a risk factor for PCR. There may be some machine-related factors which can lead to PCR, like if we don't have good settings on the machine, there's a lot of surge which is there in machine, or if there's sudden intraoperative machine dysfunction, if there is inadequate brightness of operating microscope, there's poor visualization, you're not able to visualize properly, it increases the chances. Or there may be sometimes interruption of infusion flow because of the bottle finishing midway, the infusion bottle, or there is loose irrigation line. The irrigation line may come off from the phaco handpiece, or if there's sudden kinking in the tubing, it can cause the sudden interruption of infusion flow, which causes sudden AC collapse and posterior capsule may get ruptured. And of course, there may be surgeon-related factors. In experienced surgeons, PCR incidence is higher. There were various studies which have showed that residents, of course, have a higher rate as compared to the experienced surgeon. So now let's see that what are the early recognition of PCR? How can we recognize early? Because the earlier recognition leads us to take some steps which further decreases the chances of the uneventful complications which can occur in that case. So you may notice that there is sudden deepening of anterior chamber when PCR occurs. There may be pupillary snap sign. This was described by Dr. Ronaldo in '96, that this occurs during hydrodissection. When there is a hydro rupture of the posterior capsule, the pupil suddenly it constricts suddenly for a moment. And so that is called as pupillary snap sign. So if you are careful enough, you can see that during hydrodissection. And there may be increased red reflex, especially if there is a localized posterior capsule rupture. And you'll realize that the tremulousness of the nucleus has increased, and there is difficulty in rotating a previously mobile nucleus. because now if vitreous is there, it will clog the phaco handpiece also, so that the pieces won't stop coming in the phaco handpiece, and nucleus also stop rotating as it was previously rotating. So you can also see the pupillary margin movements which are inconsistent with the AC manipulation by instruments. So this is a subtle sign. If you are doing something on the side port, but you see that the pupil is peaking, means there is a vitreous strand which is causing that movement of the pupillary margin. Or you may see, of course, strands of vitreous nacre. So now let's go through the video and understand the basic principles which we have to follow. So the occurrence of PCR is not an issue. The problem lies in improper handling of the posterior capsule rupture when it happens. So this is the most common setting where we can get a PCR. This is a typical posterior polar cataract. As you can see, it's a onion ring shaped structure here. So we all know that we always have to be careful at each and every step of dealing with posterior polar cataract. The capsular axis size has not to be more than 5 or 5.25 millimeter, because if there is a big posterior capsule defect, in which case we are not able to put a single piece IOL in the capsular bag, we need to put a 3-piece IOL in the sulcus, and then we need to do optic capture. And to do the optic capture, we don't need a bigger anterior capsular axis. So the first step is that size of the capsular axis has not to be more than 5.25 millimeter. And of course, we all know in a true posterior polar cataract like this case had a nucleus grade 3 along with posterior polar cataracts. Limited hydrodelineation is done to delineate the endonucleus from the epinucleus. And once you're done hydrodelineation, you go with the phaco and try to do direct chop. And if once the first chop is done, I just rotate my phaco handpiece on right side and take out the endonucleus like a piece of cake, and then turn to other side. So the aim in these kind of cases is always try to do layer by layer separation of the nucleus, so that the weakest area which is there at the posterior pole is attacked in the last. So we take out this endonucleus here. So once this endonucleus is taken out, now we are left with the epinuclear shell here. So this epinuclear shell is loosened up from all the sides slowly. And once we have loosened it up from all the sides, we just try to flip it. So this is the last piece of the epinucleus which I have reached here. And you can see this is the area which is the weakest area. And so our aim is to try to delay opening of the posterior capsule as much as possible. So here, once this sheet is taken off, now you will realize that I can visualize that there is a posterior capsule rupture there. So I just take off this epinuclear sheet which is there. And once you have noticed this posterior capsule rupture, you just don't come out from the anterior chamber withdrawing all your instruments, because you don't want to further enlarge whatever posterior capsule rupture is there. So you put OVD from side port, take off your chopper and put OVD, whatever OVD is there with you on table, HPMC, or if you have a dispersive viscoat like this, that's the best, because it goes there and plug the defect. So this is the case under topical anesthesia which is going on. So now is the time that you have a lot of cortical matter there in the anterior chamber. There is a vitreous which I could see because the posterior capsule rupture is there, and you can see there is increased red glow, of course, there. So now the aim is to do first stain this vitreous, do adequate anterior vitrectomy to clear off all the vitreous from the anterior chamber before you take off this cortical matter. because this viscous substance, vitreous, if it's there in anterior chamber, you can't clean this off, and you should never do, because that will lead to traction on the vitreous base. And remember that at vitreous base, retina is 100 times thinner than in the center. So it causes a lot of traction, and this causes the main problem in the post-operative period, that if you're not careful, you causes retinal breaks, and which leads to retinal detachment and consequent post-operative complication. So here you need to go and put triamcinolone to stain the vitreous, visualize the vitreous. You can use either the same concentration or you can dilute it to 1:4. And once you have taken off the excess triamcinolone which is there, you need to go and do bimanual anterior vitrectomy. So the aim of vitrectomy here is to cut the vitreous. At this stage, there's a lot of vitreous there. So the settings which you want on your vitrectomy machine is the highest cut rate which your machine gives. Like my machine gives, it's a 10,000 cut, it gives Ferro's machine, or 5,000 or 6,000, whatever highest cut rate your machine gives, you need to keep settings on the cut and then aspiration mode. So, and one very important thing for all the younger surgeon is that you should prepare well for all these things whenever you are at peace. So there's a saying in army that the more you sweat in peace, less you bleed in war. So it's not like that you're not well versed with doing vitrectomy and all these things, and suddenly PCR happens, and then again, everything goes haywire. You are not able to do adequate vitrectomy, and that causes the problem in the case. So you should know your machine well. You should know how the cutter works, and what are the principles. So basic principle of vitrectomy, it remains same for years. The principle are same. Either you do limbal or through pars plana. Many surgeons to pars plana vitrectomy. If you are trained enough, of course, you can do pars plana. That is, of course, better than pars plana, the limbal route. But if you are not proficient, you can very well do through limbal route also, taking care of all these principles. So your cut rate has to be highest possible so that you can shave off the vitreous nicely. Your aspiration vacuum has to be low, 150, 200 low, so that you want to cut the vitreous and then aspirate it. So once you have done adequate anterior vitrectomy from the anterior chamber, then is the time that you try and go and do the cortical irrigation aspiration in the case. So I'll just skip this. So once you have done, again, don't let anterior chamber collapse. Sorry, I'm so sorry. Okay, so where were we? Yes. So never let your anterior chamber collapse. Again, I'm putting this chondroitin sulfate based OVD, this viscose which goes before you withdraw the irrigation handpiece and before you change your hands. So now, once I've done the adequate anterior vitrectomy, now I can strip off the cortical matter nicely. So you can very well appreciate that there's a big posterior capsule rupture which is there. So this you can only do once you have cleared the vitreous entirely. Again, I'm doing OVD exchange before I change my hands, and now. So this is the last part of the cortical matter which is taken off. So now, once you have cleared the entire capsular bag from the cortex, so you need to put that's why you need a capsular axis which is not large. And again, I put OVD, and the 3-piece IOL is planned. So 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 3-piece IO So, and in cases like this, your incision should be large enough so that you can, put your nozzle nicely in the anterior chamber. So 3-piece IOL, they are a little bit tricky to implant as compared to single-piece IOL. So the trick is to always keep this leading loop horizontal when it's coming out, so that it goes first in the sulcus, keep it horizontal, and then turn your hands in the anti-clockwise direction so that it opens up. So once you're leading haptics in the sulcus, you can then dial this 3-piece IOL in the capsular bag. And after that, you need to capture the optic behind the anterior capsule. So I put this, dialed it in the capsular bag. My haptic are perpendicular to the tear. Again, put some OVD, and then use a Q-glance hook to tilt it and capture it through the anterior capsular axis margin. And you can very well retract the iris and check whether it has been captured nicely on both the sides. You'll see kinking of the anterior capsule in the area where the optic haptic junctions are. And then put some myocol to see where the pupil is constricting nicely. If there are any vitreous strand, you can cut them. And hydrostitch all the incisions. And if your incisions are leaky, you can very well suture them. It's very imperative that you hydrostitch them well. And that finishes the case. So these are the post-operative photographs. You can see that lens is nicely sitting in the capsular bag, and this is a posterior capsule rupture which was there, and this is the optic capture which has been done in this case. This capture is important for long-term stability of the IOL. And a thing about the IOL power is that if you are doing optic capture, you don't need to change IOL power. You need to use the same IOL power which you have taken out. Now, another scenario, again, typical posterior polar cataract. The thing, it has been taken off epinuclear sheet. So whenever you have a PCR, it's not always mean that there is vitreous disturbance or vitreous is there. Look into this case. There is a tear in the posterior capsule, which was expected because it was a true posterior polar cataract. So now here, what I see that the fluid currents are normal. I can see the posterior capsule tear which is there, but there is no vitreous prolapse. So again, the principle remains same. You need to maintain closed chamber. So here, instead of OVD, I put irrigation cannula, which is attached to second BSS bottle. So before withdrawing phaco handpiece, I have 2 irrigation cannulas. So one irrigation cannula goes in before taking out the phaco probe. And I start doing aspiration. So you can see I'm doing cortical aspiration nicely because there is no vitreous in the anterior chamber, and the irrigation from this cannula, it goes toward the angle above the iris plane, so that it's tamponating the whatever vitreous phase is there. Vitreous phase is not disturbed in this case, so I don't want to disturb it further. Again, the second irrigation cannula goes in before I take out the first cannula to maintain the chamber. And the entire the capsular bag is cleaned off. And you can see there is a posterior capsule rupture which is there, and it's just dancing like a trampoline there. I think you can very well appreciate. But whenever we have a tear like this, small tear in the center, we should always try to convert this tear into a posterior capsular axis so that we can put a single piece IOL in the capsular bag. If you are able to achieve that, you can very well put a single piece IOL. So here, before withdrawing my irrigation cannula, I'm putting OVD again. There's an OVD which goes. So OVD goes, irrigation stop, and then I come out from the chamber. And then use a microcapsulorhexis forceps to convert this irregular tear into a regular margins. So if you are able to achieve this, you can put a single piece. This is a preloaded IOL. So be careful that your leading haptic, that both the leaves are inflated. The leading haptic goes nicely in the capsular bag. And you don't try to dial the lens, you just bend it from the haptic and push it through the anterior capsule margin. And this finishes the case. I'll show you the post-operative photographs, then you'll be able to appreciate it much better. So this is the slit lamp video, which shows, have a look at this. So this is the anterior capsulorhexis. And this is the posterior capsule tear, which was converted into a posterior capsulorhexis. So these are all regular margins. There are no weak areas there. I think you can appreciate here now. So if you're able to achieve this stability in posterior capsule, then you can very well place a single piece IOL in the capsular bag. Of course, if you want to put a 3-piece, you can place a 3-piece IOL. Now, another situation, you may have some cortical material or some small nuclear pieces in the anterior chamber. So in that case, again, posterior capsule tear is there. I just push this nuclear piece on one side, convert it into a posterior capsulorhexis. And once I convert into posterior capsulorhexis, I put an IOL, which acts like a scaffold. So if there are smaller pieces there, so you can very well put an IOL. This technique is shown by Dr. Amar Agrawal. Brilliant idea that you can put an IOL. So its optic acts like a scaffold and it doesn't let the smaller pieces which are there to fall in the vitreous. So once I put this IOL, I take off the remaining soft material which is there and then clear off the capsular bag. And this is the last case. Again, patient was under topical. You can see the movement which the patient was having. So I stabilize with the visco cannula, do capsulorhexis. So start doing phaco. Now see what happens. I have not done any hydrodissection in this case because the cataract was mature. Just start doing some drilling in the center. And I just start to chop the nucleus, taking off the epinucleus which is there. And now see what's happening here. That I suddenly realize that lens is tilting on this side. So I thought, okay, let's try to chop again. Because I didn't do any hydrodissection, I was not expecting anything, but see suddenly what will happen? Nucleus is tilting more. And here, it's sinking like a Titanic now. Now, what I want to emphasize here is if nucleus is going like this in the vitreous, in the anterior vitreous, you should never go behind chasing it. So it's gone now. It's not your domain because we have VR backup. So now it all depends. If you don't have VR backup, you just close the case and refer to VR surgeon. But don't go chasing around this falling nucleus, which is there in the anterior vitreous. Don't go and chase, just try to scoop it out with all those instruments or posterior levitation should never do, because it will further complicate the situation and leads to the untoward complications in this case. You should just say goodbye to this nucleus and refer it to your VR surgeon. So you should know that what are your limitations and where to stop in a case like this. So I think with this, I'll end my presentation. Thank you so much for giving wonderful opportunity.
Thank you, sir. It was a wonderful presentation. You actually covered all the steps that we can have as a complication in a case of a posterior capsular rupture. So just to complete the discussion, what are the settings that would change if there's a rupture that we see while we are doing the phaco, in the initial stage of the phaco where half the nucleus is still there?
Yeah. So see, whenever we notice that, yes, PCR is there, we need to reduce down on all the parameters. We need to reduce down on the bottle height. If bottle height is 80 to 90, we need to reduce it down to 30, 40. We don't want more pressure pushing it, the nucleus. We should reduce down on vacuum. We should reduce down on flow rate. So everything has to be lowered. So that's what you need to change.
And in one of your cases, you showed that you had used the irrigation port. What are the cases where an anterior chamber maintainer might help?
Yes. So that was the case where PCR was there, but there was no vitreous disturbance, no disturbance. So in those kind of cases, some surgeons like to use anterior chamber maintainer, but personally, I don't use ACM because I think that that adds to another extra stab incision. Then you put an anterior chamber maintainer, but that's also a good idea. If you are used to an ACM, you can very well put the ACM. The principle is same, that it maintains the anterior chamber. So we don't want any fluctuations. These are the fluctuations in the anterior chamber which causes the problem more. So if you can maintain it either by ACM or by OVD or by using the separate irrigation cannula, as I used in that case, you can use whatever you want. But principle is same, maintain anterior chamber.
And the scaffold technique was beautifully demonstrated. I think, Aarti, you have further questions for sir.
Yes. So thank you so much, sir. I will say youngest ophthalmologist for that nice video-based talk. You have showed us, sir, very wonderful cases. So you were operating, almost all the cases were under topical anesthesia. So as
Yes.
youngster, as young ophthalmologists, so do you suggest us to take the risky cases under local?
No. Initially, of course, you should take them under block, because of course you may need to do vitrectomy and all those things. You never know. So of course, as you graduate and as you become more experienced, you know that you can handle them, under topical anesthesia also. You can take them under topical, but initially, of course, you need to block the patient because they do take more time than normal. So you have to give block.
So if in case we are doing a case under topical anesthesia and then we don't expect, pre-operatively, there are no risk factors and we don't expect anything to happen intraoperatively, but it happens. So how would you suggest us to supplement the anesthesia?
You can give subtenance anesthesia. That's a very good way, which gives adequate anesthesia for your maybe pars plana vitrectomy also to complete under subtenance. I personally don't do pars plana, but my VR surgeon, he does under subtenance, and a lot of surgeons are doing it. Yes.
Yeah.
So one more thing, for the beginners, would you suggest that all the anterior segment surgeons should know pars plana vitrectomy, or anterior vitrectomy is good enough to manage these kind of cases?
See, it depends on the type of setup where you are working and the type of training which you have undergone and all those things, But if you follow the basic principles, you can get away with limbal vitrectomy also and through pars plana also. For years, we all have been doing limbal vitrectomy only, and pars plana has been advocated years back by many surgeons, but now more and more surgeons are going for pars plana vitrectomy, but they have their own disadvantages. No, if you're not proficient in doing pars plana vitrectomy, you may end up creating more problem. No, you don't know how to enter properly, and these are things which we don't do routinely. No? So it, we do once in a while, so we can't be more proficient in that.
And your last video was excellent. The learning that you need to know when to stop is the most important while we are just in our beginning stages. So.
Yes. So
when to stop and say goodbye to the nucleus.
Yes. Like your girlfriend, no? Say bye-bye. So see what happens that PCR is a known occurrence, but problem only happens because of the not handling it properly. Believe me, the most litigations to surgeons have been because of the not properly handling the PCR, and because of the complications related to retinal tears, retinal breaks, and retinal detachment, and all those things. So never use these sponges and all these levitations and all those things. They are disastrous to the vitreous base. So it's better to see, you should never shy away from telling the attendants of the patient that yes, nucleus has fallen down and it will be taken out by VR surgeon. That's it. It's very simple. Rather than just try to think that taking out nucleus will do everything. No, it's going to create problem in the coming months. So I think VR surgeons are there. Devakant is there, and a lot of VR surgeons, they know better. Veer is there, yeah.
So we will come back to pars plana vitrectomy and VR surgeons' point of view. Sir, I wanted to ask one question. You showed usage of triamcinolone once you have noticed that there is a vitreous loss. So do you routinely advise using this, or
Yes.
you selectively we should go for it?
No, you should use it. Yeah. You should always try to stain and visualize, because we may miss small strands, which are there.
So at what stage, let's say if there is already some vitreous which you can see in the pupillary area, and should you clear the vitreous first, then put the triamcinolone, or as soon as you see the vitreous loss, you put the triamcinolone? My question may be very basic, but I'm anterior segment surgeon, so I would like this to be clear.
No. It's a very pertinent question, and I think you should put triamcinolone as soon as you notice that. See, the first case which I showed, we can very well see if PCR is there, a lot of red glow is there, and a lot of vitreous is coming, and it's so we have to go and put triamcinolone first, visualize whatever vitreous is there, do vitrectomy, and then try to take off whatever nuclear piece is there or whatever cortex is there, because if you don't clear it off, then it will cause traction on the vitreous. That will create problems.
Okay, sir. So do we have any more questions for Harshul sir from the audience?
Can I just add to that as well?
Yeah.
Please, Dr. Veer, go on.
Yeah, so I think like sir has beautifully shown his videos as well. As soon as you notice the PCR, so usually your phaco handpiece and everything is inside and chamber is maintained. So try to just quickly take out the nucleus as much as possible. If a piece goes down, no problem. And right after that, leave the cortex, don't go off the cortex. That's when you inject, basically, as soon as you've taken care of the nucleus, inject triamcinolone.
Okay. So Nandini, should we move on to the other talks?
Right. So thank you, sir. So it was
Okay.
a lovely
Thank
video
you.
presentation. I hope your last video to say bye-bye wasn't that you're leaving from our portal right now.
Yeah, I have some commitments, so I so wish to stay, but I'll have to leave. But
Right.
Thank you so much, Dr. Karan and Dr. Aarti, Dr. Nandini, everybody. for having me here. Thank you so much.
Thank you,
Thank you
sir.
so much.
Okay.
So we will look forward to again disturbing you if we have any further questions or
Yeah. Okay. Okay. Bye-bye.
Thank you.
Bye, sir. Thank you.
So we move on to our next talk, which is by Dr. Nikunj Tan. He is a cornea and a cataract refractive surgeon practicing at SRJ Netralaya in Indore, and he is also a very dear friend. So Nikunj, please start with your video.
Thank you, Dr. Nandini. I'll just start sharing my screen here. Is it visible?
Yes, Nikunj.
Like, yeah, okay. It was a wonderful talk by Harshul sir, and there are always learning points when he gives a talk like this. And being an anterior segment surgeon, it is always I never stop, when there is something to learn. So I would like to thank Dr. Aarti and our Surfing the Anterior segment team and team Yossi and Dr. Karan and Dr. Devikant and whole Yossi team, Dr. Nilesh, to give me this opportunity to talk about iris claw IOLs. I don't have any financial disclosure in any of the IOLs, which I'll be giving information in this surgical video-based presentation. So why you, as an anterior segment surgeon, it is important to know how to manage a case of aphakia, even by doing an iris claw IOL if you have access to it. So there are certain plus points about iris claw IOLs, which I'm going to point out here, that it can be a savior for all anterior segment surgeons in situations where you end up with a complication, or is it you are handling someone else's complication. So it is easier to perform for anterior segment surgeon as compared to any SF IOL, any scleral fixated IOL techniques. It is cheap. The lens is cheap. It is PMMA material. It is easily available. There are few brands which make it, but it is still easily available. It helps to prevent primary aphakia if you will end up in a complication where sulcus IOL is also not possible. And so it avoids delayed visual recovery, and it avoids awkward situation with the patient if you leave with the patient aphakic. But yes, as Harshul sir has pointed out, whenever there is a nucleus drop, never put even iris claw IOL in such situations. So basically, it is called iris claw IOL because it has got a claw at the claw haptics, which actually gets tucked into the iris. So there are basically two designs. It is anteriorly fixated and retro fixated iris claw IOLs. I'll be talking about retro fixated iris claw IOLs, which is generally practiced currently. So it has a optic size of about 5.5 mm, and it has got claws at the opposite haptics. And this is the model which is made by Excel Optics from Chennai, and there are other companies which makes iris claw IOLs like. So internationally, the Artisan iris claw IOL is famous for anterior as well as retrofixated IOL. Appasamy Associates also make one iris claw IOL with the name of Liberty and Excel Optics, and one other company, I think Freedom iris claw IOLs are also available. Again, mentioning that I don't have any financial disclosures. So for calculation, you can use the A constant which are mentioned by the company, and you can subtract 1.5 diopter from the calculated power. So these are the situations where you need to manage differently apart from our routine in the bag or in sulcus IOL. So either it is a surgical aphakia where you will end up having a large PCR or not having adequate anterior capsule support as well, or there is a traumatic aphakia where there is a traumatic loss of nucleus or and zonules, and even in this case you can see the photograph that there is a loss of iris tissue in the inferior part as well, or there is a planned aphakia. Like this is the case which I handled where patient had a literally black nucleus which was subluxated temporarily with a more than 180 degrees zonular loss, and it was impossible to salvage this capsular bag. So I went ahead with the intracapsular cataract extraction and then iris claw IOL. So this is the video showing steps of iris claw IOL. So basically you need a sclerocorneal tunnel, just like we make in the SICS, and then you need two separate paracenteses. 180 degrees opposite on the temporal and nasal side. Here I'm using a SC maintainer for maintaining the anterior chamber while the procedure, and the myocol is inserted to decrease the pupil size. We don't want very small pupil sizes in this case, but if we have a mid-dilated pupil, it is preferred. So after inserting the IOL, it is oriented toward the haptics are oriented towards the opposite side port. So and then holding it in the center and bringing the haptic under the iris. Using a Sinskey hook, the iris tissue is pushed down, so it will enclave into the clip. So that is called enclavation. And similarly, the other haptic is also taken behind the iris, and the iris tissue is pushed from above to enclave it in the other haptic as well. Important thing is to do a surgical PI in serious cases, because if surgical PI is not done, then it can lead to pupillary block and cause rise of intraocular pressure. Another important thing is to do a thorough anterior vitrectomy, which I'm not going to discuss because it has already been discussed and it will be more discussed by my other colleagues. So this is another case. If there is a quadrant iris tissue loss in one quadrant, then still you can do iris IOL, because basically it needs supports from the opposite direction. So in this case, there was a loss of iris tissue in the inferior part, but you can see we are going to put an iris IOL in this case. So first, it is called priming of the iris IOL, that you should check that the claws are separating from each other. Sometimes there could be a manufacturing defect that the PMMA haptics are stuck to each other, so it should be checked before. And there is a specialized iris IOL holding forceps which appears like a duck beak appearance, and it actually helps us to hold the IOL better than a McPherson's forceps. So you can use that, and following which surgical PI was done using a anterior vitrectomy cutter. So there are a few situations where iris IOL also should be avoided if it is a case of active uveitis, because we are actually using a uveal tissue to hold our IOL, so it should be avoided. If patient has any neovascularization, if there is any excessive chafing, or there is a large iridectomy because of surgical trauma or actual trauma. If patient has any angle abnormalities like peripheral anterior synechia, iris IOL should be avoided, and any posterior segment pathologies like CNVM or CNV. And as I mentioned, that nucleus drop should never be done as a primary procedure. Right? So there are a few complications which have been documented in the literature in the multiple reports, and what I have seen is one, in my experience, de-enclavation of one haptic, which is common especially if somebody is a beginner, and if they have not enclaved it properly, if they have not appreciated that the iris is pinched into the claw or not. Another common thing is ovalization of pupil. So I'm going to show a case where why ovalization actually happens, which is actually preventable if you enclave it properly in the mid iris plane. So this is the video where, so you can see iris claw holding forceps I'm using, and the video is a little bit, there is a lag in the video. So the pupil is a little small, and while enclaving the first haptic, the enclavation is done quite nearer to the pupillary margin. And you can see the major part of the optic is above the iris plane. So that shows that the enclavation is not at the mid iris plane, but very near to the pupillary border. And for the second enclavation it was getting difficult to bring the iris claw behind the iris, but somehow it was manageable. But after second enclavation, you can see the pupil is quite stretched horizontally, and that is the reason why it becomes oval pupil. So if the enclavation is done at the mid iris plane, it can be avoided. However, the dilatation after iris flow lenses are good, so post-operative retinal examination is not an issue. So this is the photograph courtesy Dr. Karin, that in a case where there is a DMEC or a DSEC graft is also done, you can put with a patient with an aphakia, iris flow IOL can be implanted, and you can see a very good dilatation even after iris flow IOL is in the place. Just as this is the anterior iris flow, which has a smaller optic size, and it is of historical importance. But one day, a patient came in my OPD, and he was operated by respected Dr. Daljit Singh sir 25 years back, and he underwent that ECC with large incision, and he had steel wire sutures in his in near this limbal corneal junction, and he had an anterior iris flow lens that implant at that time, and still the cornea was clear and the lens is well centered, well placed, and patient had a good vision also. So this is just for historical importance, but I was amazed to see even this long-term outcome of this case. That's all from my side. Thank you so much.
So thank you so much, Nikunj. So we'll take the questions after all the 4 talks. So I would like to invite the General Secretary of EOC, Dr. Karin Bhatia, who is a cornea, cataract and anterior segment and refractive surgeon at Meerut. So over to you, Karan, for your talk. Kindly unmute yourself, Karan.
Is my screen visible?
Yes, it is.
So I'll be talking about mixed technique, which is a novel approach for sclera fixated IOL implantation. I do not have any financial interest in the presentation that I'm doing. So the ideal situation after any cataract surgery is the implantation of the lens into the back, as my previous surgeons have shown. However, it's not possible, and what we don't want is surgical aphakia. So various options have been described. The anterior chamber IOLs, I'm really against them. I don't like them at all, but they've been done. Just on a personal note, iris claws, I'm a big fan myself. Nikunj has explained them beautifully, and my other colleagues, Devakant and Veer, will be talking about the other techniques of SFIL as well. So these are the options that you have to manage aphakia when the whole bag is gone. Scleral fixated IOLs are the most popular approach, and they will be dealt by my latest speakers. For various surgical approaches are there, but the problem is that it is always a challenge for the anterior segment surgeons. So those talks will be given by the VR surgeons. I'll give you a technique which can be done by the anterior segment surgeons as well. So we describe the mixed technique, which is a modified adaptation of the Yamane and the X-net techniques for SFIL implantation, where the externalized haptic is cauterized to form a flange like the Yamane technique, and the haptic of a 3-piece IOL is inserted externally into the needle lumen, not inside the eye, but externally like the X-net technique. So therefore, MYX stands for M for modified adaptation, Y for the Yamane technique, and X for the X-net technique. A lot of people are using this technique now, and they are writing it as modified Yamane, but actually it is modified Yamane and X-net. That is why it is known as the MYX technique. So we had published this in the Indian Journal of Ophthalmology as well. So let's take a look at a case. This was a case, 55-year-old gentleman with post-cataract surgery of aphakia, and you can see there's a PI as well. Let's get to the surgical video. So first step is the creation of a Phonics-Based conjunctival flap. This technique does require you to make a scleral tunnel. So if you see over here, and if it's always better that whatever the sclera bed, you cauterize it because any bleeding will go inside into the vitreous. So you can see in this video, there's a buttonhole from the previous surgery that was done by somebody else. So then the next step would be, ideally you would want to make a side port, but over here what I've done is I've used a crescent knife to open the same tunnel that was there. You can choose a different site as well if you want, but I felt I could go ahead with this site, so I've done it in this case. So this tunnel was entered, and then after injecting some OVD into the anterior chamber, a side port incision was made, and so on the other side as well it was done, and OVD was injected into the anterior chamber. The next step was the automated anterior vitrectomy. You need to do this automated anterior vitrectomy. It's extremely important that there's not any vitreous, and slightly go beyond a little bit more, but don't go into the area of a VR surgeon, otherwise they'll eat up our heads. So I tend to change the cutter upside down and then do that area. Sweep for any vitreous. If there's any vitreous, again, do a good anterior vitrectomy. Again, I will not go into details of it. And once that is done, then you can plan your iris, this SFIL. So this is what the technique it shows is that if you look at this over here, so this is the limbus over here. So the thing is you have to make marks. The mark 1 is made about 2 millimeters away from the left side limbus. Mark 2 is made 2 millimeters on the right side of the right side limbus. And then mark 3 is 2 millimeters below this. And this is mark 4, which is 2 millimeters above it. So this is mark 3 and mark 4. This is actually where you will be inserting your, or you will be doing a sclerotomy using a 26 gauge needle. So let's take a look. So 2 millimeters over here was measured using a manual caliper. and you stain it with the pen, with the dye. And again, see, you can see the mark 1 and then mark 2 being made. And similarly, try to dry the area, otherwise the stain will not stick or the dye will not stick. So, and then you do it on the other side as well. Mark 3 has been made over here, and then again 2 millimeters from that side, mark 4 was made. So now you've got your planning. A good idea would be that the tunnel should be slightly on this right side such that it's closer. I'll tell you the reasons for that. Then another side port is made inferiorly. So this is to introduce the AC maintainer. Using an AC maintainer really helps. You will really struggle if you don't use an AC maintainer in such cases. Now this is the idea of Dr. Nikunj, that what we did was the IV bottles, the plastic that is there. So he's a co-author in this technique as well. So you cut that, and you know we are using it as a guard stopper or a PVC stopper. This is a 3-piece Orolab from IOL from Orolab, no financial interest. An angle transconjunctival sclerotomy is done via Mark 3, and it is brought into the area, the ciliary sulcus, or the area where you want to put the SFIL. And then using an iris repositor or a McPherson's forceps, you depress, take care of the iris, and bring this out of the sclerocorneal tunnel as you would do in the case of an X-Nit technique. Our markings are different from the X-Nit and the Yamane, the location. So then this leading toluene haptic is then inserted into this needle lumen, and then slowly and slowly, see the AC maintainer is turned on right now. It's already on, I mean, and then you take this, and this needle haptic complex is, once you take the IOL inside, the needle haptic complex is slightly withdrawn and this PVC stopper is applied, and this helps to prevent the slippage of the IOL. Similarly, on the other side also, you do the same thing, use a separate needle, a fresh needle, and then slightly angled, and then a transconjunctival sclerotomy is done. And then again, this needle is brought out below the IOL, above the iris plane, out of the sclerocorneal tunnel. Now, this tunnel should be slightly towards this side, because then this needle will come out. Otherwise, you will see that the problem that some surgeons face is that the needle doesn't come out, because the length of this 26 gauge needle is not so long. So you bring it, the tunnel should be slightly eccentric, not too much. And in the same way, the needle haptic complex is withdrawn from the sclerotomy side, and you can see the IOL is very well centered. Now, the next step over here would be to titrate it, and you want to check on how you want the centration to be. So this is, now it is perfectly centered. You pull a little bit of the IOL, approximately 1 millimeter, and sometimes more depending on eye to eye, and then you cut the IOL. And once this IOL is cut, the haptic is, part of the haptic is cut, then you use a heat cautery and you create a flange like the Yamane technique. You can also use a Bowie cautery, but this is more economically viable. And then this flange is buried subconjunctivally and intrasclerally also. Similarly, on the other side, the PVC stopper is removed and you trim the haptic. And again, once this haptic is trimmed, as you can see in the video, then you create a flange, and this flange is also buried intrasclerally. Now, the trick that you want to see over here is why it's important to cut the haptics and trim the haptics is you want the haptics to be taut to prevent pseudophacodonosis. Otherwise, what we have seen is a lot of cases. You can see the lot of cases is that the haptics will come out from that side. So you need them to be taut to prevent pseudophacodonosis and also to prevent the prolapse of the haptics later on. So that's what we found out. And you can see that the IOL is very well stable, and then the sclerocorneal tunnel was sutured, and this is what a pilocarpine was injected, and the conjunctiva was also sutured. So this is how on uncorrected visual acuity became on post-operative day 7. He was just reading about 612. This is another case. This is a 23-year-old post-trap 1 eye 8PL present PR accurate was the vision. He was dependent on others for the simplest of tasks. There's a thick fibrotic Descemet's membrane, retrocorneal membrane. You can see, you can look at this case. It's very difficult. You do a PK over here, or you do a DSEC, and a lot of things get complicated. And it was Aphakia as well. So what I had managed to do DSEC with an SFIL using mixed technique over here, and you can see the BCVA 618 plus 2 after 67 days. He's no longer in my follow-up. However, you can see the IOL is also extremely stable. The graft is around 57 microns, and you can see that the flanges, they are nicely intrasclerally buried over here. This is another case of a pseudophakic bullous keratopathy with an AC IOL, and you can see similarly BCVA 6.9 after 93 days of follow-up, doing extremely well using the mixed technique and the flanges over here. This is another case of a 35-year-old one-eyed patient, corneal opacity with vascularization. The B scan was anechoic. Now, this case would require, one-eyed patient, situation get difficult. So the thing is, I plan to do a penetrating keratoplasty over here, and I won't go into the steps of that, but you see a subluxated lens over here. So this lens was also removed. And after this was done, you can see that the entire back complex is there, vitreous is there, the vitrectomy was done, and you can see the entire bag was then removed from the eye. So there's no lens over here. I want to put a lens in the same sitting. After doing a good automated vitrectomy, breaking all the synechia as you would do, I'm using the mixed technique over here, and I'm doing an SFIL. It's a dangerous procedure, but I've done a couple of cases like that with good results. And using the same technique, I was able to implant a good SFIL over here. And you can see same trimming of the haptic, same process was done. And you can see now the flanges were buried. And you can see the IOL is very extremely stable. And the keratoplasty was also completed at the end. So this is how he was 660. There was the thing is, there was a persistent epithelial defect which was being managed. Again, he's lost to follow up now. But the point that I'm trying to say is that you can even do it in open sky procedure. This is the post-operative day, 45-day follow-up. So mixed technique is an easy, fast, and reproducible technique. If you use the advantages of both the Yamane and the XNIT, you can actually do an SFIL in 15 minutes, excluding the vitrectomy part. And this mixed technique actually received the AIOS IGO Silver Award as well in this this coming AIOC 2020, the previous one. So thank you so much.
Thank you, Karan. It was a lovely presentation and a very new technique for all of us, which I'm sure all the young ophthalmologists would be following as the time goes. And we will definitely need it would be a steep learning curve, I'm sure, in the beginning for us. But yes, the technique is very promising. So with this, we'll come back with the question. There are a lot of questions which I myself have for the mixed technique. But let us continue with our video presentation. So for that, I next invite our none other than Dr. Devakant, who is the Vice President of UC and is the Medical Director and the Head of the VR Services at Swamjyoti Eye Hospital, Lucknow. So Dr. Devakant would be presenting on suture SFIOLs.
Hi, so I'll be talking about the suture technique of doing scleral fixated IOLs. I know this is the age of the sutureless, but I still do this technique often and find this very dependable. So this is a case of a 50-year-old female patient who had been operated elsewhere for cataracts and then unfortunately had endophthalmitis, and we managed it initially with co-vitrectomy and antibiotics. That didn't work well. Then we planned to remove the IOL and the bag, did complete vitrectomy with silicone oil. Now the patient is doing well and we have planned for silicone oil removal and SFIO. So first and foremost, we have to make few peritomies, two smaller one 180-degree apart for the scleral pockets, and a larger one for the scleral tunnel that we'll be making. So now I'm using a crescent blade to make the two scleral pockets. An alternate method could be to raise scleral flaps instead of pockets. So this patient had a scleral tunnel made before. So here I'm just trying to open that up really carefully with the crescent blade. Again, it's really important to have a well-formed tunnel despite the challenging conditions these cases come to us. I'm using a 9-O-proline here with a straight needle at its end. On the other hand, I have a 30-gauge needle which will help us in docking the 9-O-proline. Now we have to be really careful while performing this step, because otherwise it can lead to complications. It can hit the iris on the other side and injure the retina as well. I prefer using the 9-O-Proline over the 10-O-1 because of the strength that it offers, and I feel that it's easier to manipulate the sutures as well. You can practically use any instrument to bring out the sutures. I'm using an ILM Forceps here, so whatever helps you in grabbing the suture well can be used. So the sutures are grabbed with a couple of instruments and brought out carefully and then cut right in the center. I'm using the scleral fixated IOL that has been manufactured by Oro Labs. So it's a PMMA IOL and has got eyelets in its haptics. We have to pass both the sutures from each side through the eyelets and tie them carefully. And it's really important to tie these sutures really well. Otherwise, post-operatively, we can see some wobbling of the IOL. So these micro movements can be a bit challenging in the beginning, but trust me, when you get the habit of doing these surgeries often, it becomes easier and doesn't take much time. You can take help from your assistant and ask him to hold the IOL while you are tying these knots. While inserting the IOL, you have to be really careful that you don't entangle the sutures with the haptics. So keep withdrawing the sutures through your scleral pockets while you are pushing the IOL inside. The IOL now looks pretty well centered, and we can go ahead and tie the knots at the scleral pockets. Again, these knots should be done really properly to ensure the stability of the lens in the future. But you have to keep in mind that this is the step where the sutures break most often, and especially the 10-O-Proline. So we have to maintain that balance where we ensure that we do not exert too much force that we end up breaking our sutures. Now we have to ensure that the sutures are cut at appropriate lengths so that they can be completely buried inside the scleral pocket. Because if a small part of this is protruding, that can lead to a lot of grittiness to the patient. That is it, and if you have any queries or feedback, please feel free to get in touch with me. Thank you.
Thank you, Devakant. So just to complete the talk, now I invite Dr. Veer Singh, who is also a VR surgeon at Dr. Sohan Singh Eye Hospital, Amritsar. He would be talking about sutureless SFIOL. Over to you, Veer.
Thank you, Dr. Aarti, Dr. Nandini, Dr. Karan, Devakant for having me, and the entire team at YOSI. So I'm going to be talking about sutureless scleral fixated IOL surgery. I don't have any financial interest. So sutureless SFIOLs, like you've seen Karan present, one of the techniques, mostly employ the 3-piece IOL with intrascleral haptic fixation. The earliest techniques were described by Garber Chariot, followed by the Agarwal glued IOL techniques, the XNet by the Arvind people, Yamane, and then Karan has just talked about the mixed technique. So in just few pictures, I'm going to show about the techniques and then further going on to the technique that I want to show. Garber technique is nothing but using a 3-piece IOL You create sclerotomies and scleral tunnels, externalize the haptics with the forceps, and either pull or push the haptics into the scleral tunnel without the use of any glue or any flaps. In Agarwal technique, they used scleral flaps, and then at the edge of those flaps, they put these tunnels, externalize the haptics using forceps, and then tuck them into the tunnels and used fibrin glue to secure the flaps. In Yamana's technique, this is a transconjunctival technique, is a very popular technique. They used 30 gauge thin-walled needles. They used them to make 2 millimeters of scleral tunnels and to externalize the haptics, docking them, simultaneous removal, cauterizing the haptics, and then pushing them back into the tunnels. So being a VR surgeon, I tried them all, to be honest, and but really didn't enjoy any one particular one. Most of them had cumbersome manipulations. Even I dropped a few lenses, picked them up, learned the hard way. I had mixed results with all techniques. But my search for the perfect SFIL technique continued. Until one day I came across the Karla Valley Iol on Dr. Diego Ruiz Casas, who's a VR surgeon in Brazil, his channel. And a lot of views. I liked the Iol design. So I did some more research and I came across this. This is the Karla Valley Iol. It's a single piece hydrophilic material which was started by a company called Silico in Italy. The technique seemed very simple. The videos were nice to see. All you have to do is conjunctival peritomies, localized peritomies, create scleral flaps, just pinpoint 23 gauge sclerotomies, and then just externalize the haptics. That's all you have to do. So I emailed Dr. Carlo Carla himself. He did respond and he put me through to Silico, but I got no response from them. So I went back to doing the 3-piece IOL techniques because I didn't have any option. Until one day when I spoke to Dr. Navian, who's also an SN alumni, he told me that he's working on a similar design IOL, and which will be out soon. Meanwhile, Karla Valley Iol went to MD Tech, which is also an Italian company. So I reached out to MD Tech, and they quoted me a cost of 180 euros, which is approximately 15,000 plus the import duty, taxes and all. And you know how well our Indian patient is when it comes to paying for a surgery. So again, that was ruled out. So my wait continued, and then finally the day came when Appasamy launched the Swiss Fold CMT T-Flex IOL, which was a single piece hydrophilic scleral fixated IOL, which was designed by Dr. Navian at MNI Hospital. This is what it looked like. It comes with a normogram supplied by Appasamy. It's a foldable hydrophilic IOL. Sutureless scleral fixation, goes through the best part is it goes through a 2.8 millimeters phaco incision. The sclerotomies are to be made at 1.5 to 2 millimeters. Larger white to white eyes, it can go up to 1 millimeter. Shorter white to eyes, you can keep up to 2.5 millimeters. This is the total length of the IOL is 14 millimeters. Comes with forceps, some T-flex forceps and grasping forceps, but in my experience, any serrated forceps would just work perfectly fine. So I'm just going to be showing the video as to how simple and easy this technique is and how my search for a perfect SFIL technique ended. And this is my go-to technique in just everyday OT. So this is a SOR plus SFIL. First, I've made the sclerotomies, the scleral flaps, and the sclerotomies under the flaps as well. After removing the oil, all it takes is just a 5 to 7 minute procedure to just implant the oil, and you'll see how easy that is. So I use a serrated forceps, which is a max grip like forceps, to just pull out one haptic, and one side is done. And then using a handshake technique, grasping the shoulder of the IOL, externalizing the other haptic on the other side. And then you can glue these flaps up, or you can use vicryl sutures to close them up. And that's all. And you see how stable the IOL is. This is another status post vitreous surgery, Aphakia. Here I've used pockets instead of flaps, which work equally well. And these are the dedicated forceps which are provided by Appasamy. This is the T-flex forceps. Here I'm going slow because viewing the T haptic is very important, and grasping it properly is important because there are some air bubbles. So I'm going slow here. You can either grasp the haptic from the side of the tip, or the center is usually better. Important is not to pull the IOL till the time the entire IOL is injected. Here you see the last part of the IOL is still stuck in the corneal incision. So I'll push that in first. And once I push that in, it's injected. The leading haptic is externalized while holding the trailing haptic. And then the similar thing is done on the other side. This is the grasping forceps, which you use to hold the shoulder of the IOL, and then externalizing it with the T-flex forceps. And yeah, that's about it. Here a little pop, the haptic is out, and then the best part is the stability, and which in fact increases with time. As much as the fibrosis takes place, the stability keeps increasing. And I've had very good experience with this IOL. It's cut down a lot of my chair time with SF IOLs. And the results, the surgical outcomes, because of it's a small incision and the stability, the astigmatism is also very less. And that's just the last part of it, closing the conjunctiva with Vicryl, just hydrating the AC entries, and just removing the vision, and that's about it. In fact, it was even featured at Dr. Udit Devgan's cataract coach. I submitted a video and he featured this. So thank you for that.
Thank you so much, Veer. I mean, I'm really excited to try this technique and this IOL. So thank you all the speakers. Moving on to some question answers. We have few questions from the audience. So this question is for you, Karan. What are the pros and cons comparing the mixed technique and the glued IOL technique? This is from Dr. Prashant Girish. Karan, you are muted.
Yeah. So I've not done glued IOL myself. I've used the Gabber's technique, and like we have tried a lot of techniques as well. The disadvantage is that you need to make a scleral tunnel, and you can't do it from a 2.8. For the mix, and the advantage is it's fairly easy to do, and anterior segment surgeons can also do it. Another advantage of the mix is that you don't need to make scleral flaps. A disadvantage, again, an advantage of the glued IOL would be that the haptics go underneath the flap, so you don't have any risk of extrusion of the haptic. That's why what we're doing, Nikunj and myself and my other authors, what we did was after doing a lot of cases, we trim the haptic. And there's another question from Zen on this. I've just used the Orolab 3-piece lens. It's a good lens. I'm not saying like the foldable lenses. Some of the companies, the attachment of the haptic to the optic is not great, so it can come out. But the Orolab 3-piece lenses, the rigid ones that I've used for this, they are very sturdy and they do pretty good. Yeah.
Okay, so we have another question for you, Veer, which I see that you have answered, but maybe you can just speak out. T-Flex lens now commercially, is it available? And what is the cost of it? This question is from Dr. Nilesh Kumar.
I've been using it for the past year and a half. In fact, I even have follow-up for a year and a half now. It's available around, I think, something around 2,000 rupees with Apaswami, the cost to the doctor.
Okay, so next.
That's the local Apaswami person.
Okay. Next question we have from Dr. Aditya. Maybe Dr. Divakant, if you are around, you can take up, or any of the speakers can answer this. What will be your choice of secondary IOL for a patient who has glaucoma, then had surgical aphakia and a complicated surgery, and probably will need a trabeculectomy in future? So Dr. Divakant has some network issue. Maybe Karan, you can answer.
So this is going to be a big debate. It depends on surgeon's choice, I would say. But there's any inflammation in posterior segment, do not do an iris claw lens. Otherwise, if everything looks pretty normal, I would still do iris claw if the iris and everything is good. But if if you have any reservations about it regarding the inflammations, there's going to be a lot of post-op inflammation in such a case, then SFIL is the way to go.
Okay.
So can I answer that as well?
Yes, please.
Yeah. So I think he's
just somebody, can the host please unmute, make Devakant also the co-host? Yeah. Yes, Veer, please go ahead. Yeah.
I think he specifically asked if you need a future trab. So if you need a future trab, I'll probably spare the superior conjunctiva and either do this side flaps T-flex or a Yamane probably.
The case that I had shown also, one of the cases of DSEC with SF that I had done is actually post-trab eye. Two of those eyes were post-trab. So iris is
future trab.
Yeah, but still they need to preserve it. So something like a mix or a Yamane could be so. Yeah.
Looks like Aditya has given the difficult situation put together in one patient. So Dr. Devakant would like to say something. Yeah.
Exactly what Dr. Veer has just said. You need the superior conjunctiva. You need to preserve that. So anything that spares the superior conjunctiva would be the choice. And I think for my technique, the sutured SFIL, then that's ruled out. Or probably at times you could change the location of the, go for a temporal incision or something like that. But in that case also, then your small scleral pocket comes in the superior conjunctiva. So that's ruled out. So Yamane or the other techniques would be the preferred choice.
Okay, so next question is from Dr. Prashant. How is the corneal endothelial cell count post-iris claw lens? So maybe, Karan, if you have some experience with claw lenses, you can answer this one.
I have not measured it, but I believe that there shouldn't be a problem. It should be like any anterior segment surgery that you're doing. So presumably we're talking about the retrofixated IOLs, iris claw lenses. I have no experience and I do not want to do anterior chamber lenses. I am really against them.
So I can answer that. Yeah. Literature, whatever literature that I've read, that says that a normal traditional iris fixated lens and a closed loop ACIOL, those are the ones which cause endothelial cell loss. So if it's an open loop ACIOL or a retrofixated, they have and even a SFIL, they have comparable endothelial cell loss. So that's what the literature says.
Okay, so in continuation, this question is by Dr. Rashmi Malhotra. Some people are still doing anterior claw lenses. Do they take IOL power as we do in ACIOL? So to complete that discussion, can we just discuss about how to calculate the IOL power when you have intra-op complication and you want to change the location of the lens? So maybe Veer, you can start and then other panelists can just add to that.
So I'm completely against those ACIOLs and the normal iris fixated lenses. But with these, most of the modern SFIL techniques, some of them imply the concept of the sulcus IOL calculation. And in fact, the T-flex that I showed has a IOL calculation of an emetropic eye, the normal in the bag IOL calculation. So that's about that.
Dr. Karan, would you like to add something to that?
For SFI, for iris claw lenses, it depends on your A constant. Again, I would say I use only retrofixated ones. I don't do anterior ACIOLs at all. I do not do anterior fixated IOLs as well. Iris claws. So posterior fixated, the constant that I'm using is the XL lenses. The constant is A constant is 117.2. So depending on that, how you calculated, you put it into the machine. If you use the calculation is using 118.7, you would subtract 1.5. If you calculated using 118.2, you would subtract 1 from that power. That's the same. Yeah. Does that answer the question?
Yes, very well.
Here, how would you change your IOL power calculation for SFILs? Would you plus or minus? How would you do it?
So, like I said, if I'm doing a 3-piece IOL, I would plan for like a sulcus. So I would reduce half to 1. And if I'm doing this T-flex, that is emetropia. It's in the bag. So first minus I would take in my optical diameter.
I'm yet to try the T-Flex. I have 2 of those lenses with me, but
because it has like a slight curvature to it, so it's little in the posterior part of the.
Have you faced any leakage of the haptics? Some of my friends have told
I
me.
broke one haptic. One haptic I broke. I've done around almost close to 70, 80, even 100 lenses. So I broke one haptic. I took it up the very next day and I changed it. I put another T-Flex lens.
Okay, so we have another question from Dr. Siddharth Madan. Cost of Swiss Fold CMT Flex IOL. So Dr. Veer has answered that it's around 2,000 rupees available with Appaswamy. Any other question we have from any of the audience here? Dr. Nandini?
No, I think just to complete that question, Karan, can you just answer what would be the calculation for the ACIOL? Though none of us are actually doing ACIOL nowadays, but I think the question actually was how would you
Actually, I have forgotten. Was it -3 as far as I remember?
Yes.
Yeah, because I haven't done since my residency days, and that is one thing I say: leave the patient aphakic, but don't put an ACIL. Because as a cornea surgeon, so many endothelial decompensations I have seen post ACIL. Probably it's the problem is in the technique and the choice of the size of the ACIL. But
speaking, I don't think so. ACIL has been an age-old technique. You know, the way the ACIL is placed is very important. It has to be placed horizontally. I am not advocating ACIOL over here, but if somebody is using it in situations, make sure that it is placed horizontally and you do a surgical PI to save the corneal decompensation and the post-op rise in IOP. So, and the calculation is definitely by 3 diopters, it is reduced. So,
Nandini, one of the reasons I think it's a problem is the sizing. Second thing I feel is they don't do a vitrectomy, automated vitrectomy, and that's extremely important when you're doing any case of a rent. Always, if there's a sulcus available, try to do a sulcus implantation of a 3-piece lens. But yes, again, I really like the iris claw lenses, and we are disagreeing over here. But but the thing is,
I don't have any experience in iris.
Iris claw lenses, you can do one, you can do the other, and teach the third. It is that simple to do.
Right. And iris claw lenses, the enclavation and the disenclavation, actually the cases like Rikunj had said, the de-enclavation is actually very less. People think that the iris claw lenses would de-enclave, but really if you have done the enclavation properly, which again is in the mid periphery, it doesn't de-enclave that easily. So, and I think we all are doing iris claw lenses. So it is much more easier to do that than an ACIOL. I don't know how many of you agree with me.
Nandini, the explantation of ACIL, I've done a lot of DSECs where I've explanted the ACIL. You have to sometimes cut the haptic also, and you must have also done. So it's not that easy to explant an ACIL. Same thing with iris claw, you have to sometimes cut the tissue if you want to explant an iris claw lens. There's another question by Dr. Priyanka Wag. Is there any short-term course to learn pars plana vitrectomy in SFI? Vivekant Veer can probably take that up.
I can only smile to that question. So I think there's no shortcut to anything. I mean, personally, I do a complete vitrectomy when I do a SFIOL, but I think a good anterior vitrectomy is a reasonable option. It's only hit and trial. You have to keep practicing, see the technique that you like, try a few, and then finally just stick to one that you eventually like. So, like, I think people have been asking questions about CMT. It's not all the way it looks. It's much difficult, much tougher as to do it when you're doing it. So, few downsides are you have to handle the IOL very gently. The haptics break if you pull too much. Another downside I have noticed is that there's a lot of, since it's a hydrophilic material, so there's a lot of iris pigment on it sometimes, some cases. And then the third thing is we don't know about the long term because a lot of hydrophilic IOLs have been known to become opaque. So that's another thing. And if that happens, what we're going to do with the fibrosis and everything, we don't know at the moment. So I think the only thing I can is only the hard way. There's no shortcut to learning SFIOL technique. and keep practicing, I guess.
I'll just add to that is that if you do not know, if you're not a trained VR surgeon, don't attempt, a proper vitrectomy. Right? I'm talking about the pars plana vitrectomy. One way that I have been doing
anterior vitrectomy can be done. There's no problem with that. Yeah, so that can be done. But of course, no anterior segment surgeon would venture into going a full vitrectomy anyway.
So what I am doing sometimes the vitreous is coming a lot. When you're doing via the limbal route. So what I do is using an AC maintainer or using my irrigating source from a side port in the anterior chamber. I make around 3.5 or 4 mm cut with an MVR after taking a stab entry, and then I go with the cutter with the direction up, and it does really well.
That's how you're supposed to do it. Yeah. So basically, even all anterior segment surgeons are supposed to handle cases of malignant glaucoma as well, right? So what do you do? You put an AC maintainer or a infusion in the AC, and then do a vitrectomy, anterior vitrectomy through a 3 mm pars plana incision. So I think that's a very reasonable thing, and that in fact maintains the anterior segment integrity even better.
Yes.
So Dr. Harshul is back with us, if I'm not wrong. He wants to know cost of iris claw lens and which company is preferred one.
So iris claw lenses, I'm using the XL lenses. Zen is also here. Zen uses a lot. That costs around 560 rupees to us.
Okay, so we have one more question from.
Are you there? What are you using? There are anybody else is using iris claws? Okay.
I also used Excel only. I have used Excel, but Appa also has the same model.
Zain has answered IOCare iris claw lens is what he is using. And Freedom. So we have one more question from the audience. Does anyone recommend using ACIOL these days? So I think we have had a big, long discussion on this. Today I saw a patient, 82-year-old female who was mother of a physician. She presented with corneal decompensation, bullous keratopathy, secondary IOL, ACIOL placed, and there was no PI done. She was already on 3 anti-glaucoma medication and the pressure was 25 to present with and was referred for further management. So we all know that ACIOL give a lot of challenges to anterior segment surgeon. Anybody would like to comment anything or say anything?
I think we have Dr. Harshul back with us. So sir, can you please take up this question? If sir is there.
Now I really can't see him. That's why I didn't. Okay.
So I think it all depends on the optic nerve status in this case. Firstly, it's that. And then I think probably job of a cornea and a glaucoma guy to put in a valve and do a DSEC, and cephale we guys can do in between.
Yeah, so optic nerve was 0.4 for the right eye and 0.8 for the left eye. So what I did was I did a YAG, I did a iridectomy today, YAG PI, and I just told the patient that let's review in 2 weeks' time, and shifted from prostaglandin. I just shifted patient to brimonidine and timolol, as we all know that carbonic anhydrous we don't want to use when the corneal decompensation, and then patient was on prostaglandin and dorzolamide. So I think we had a very interesting session and we have overshoot the time. And we are towards the last part of our session. And there is another question from the audience. The power depends on the A constant as it takes into consideration effective lens position. So it's a question. The power depends on the A constant as it takes into consideration the effective lens position. This is from Dr. Survey. Karan?
Yes, it's on the basis of the ELP only. That's why the constant that you use.
Yeah. So, So, Karan, over to you from here onwards.
Nilesh, can you share the screen, please?
Yes, sir.
So we will now be, let's share the screen. Yeah. So we will now be announcing the results of the surgical IOC's surgical anterior segment video competition, which we had on 26 June 2022. We had a lot of entries. Next slide, please. And we thank our judges, Dr. Rajesh Sinha. Next slide. Dr. Harshul Tak, who was with us in this session as well, and Dr. Amit Porwal. Sir, all three of them, were fantastic judges and gave us a lot of tips and a lot of learning points for the young ophthalmologists. So these were the finalists, 11 presentations we had, excellent presentations. And coming to the winners, the third prize goes to Dr. Zain Khatib. So just a second. So Zain had presented on Rex's Runaway Rescue, a beautiful video. The second prize goes to Dr. Prasanna V. Ramesh, who presented on the watchful redemption from the domino effect of a mistake, complication management in a combined surgery case. And the winner of the competition is Dr. Kavya Chandran, who had presented cataract surgery post-radial keratotomy demystified. So congratulations to all the winners. You will be receiving soon Amazon gift vouchers from UC. How was the experience, all three of you? Zain, Prasanna and Kavya?
Can we unmute them?
Yeah.
I've sent a request to Zain.
Yeah, got it. No, at the outset, I would like to thank Team YOC for this initiative because it was great learning that day. All the 11 videos was great learning, and I think we are keeping some activity going, and I think kudos to everyone who was being part of it. Yeah.
Hi, Karan. Hi, everyone. Thanks to the judges and YOC, first of all, for giving this opportunity. It was a very good session overall. I think it overshot time by a lot, but I guess that was because there was a very good, healthy discussion after each video. So it was very nice. I was very happy as to how keenly the judges followed all the videos and discussed it in detail. It was very nice. Thank you for the award.
I think Dr. Kavya is not here, but the competition was very tough and intense, and it got pretty close. There were some amount of marks were also taken from the online voting. So thank you for the voters as well. So Aarti, over to you for the next part.
Yeah. So Nandini.
Yeah. So I would thank all our speakers, Dr. Karan, Dr. Veer, Dr. Harshul, Dr. Devakant, and Dr. Nikunj for the excellent video-based presentation. It was a good learning for all of us. And just to conclude, our next session would be on the 27th of July at 9 p.m., which would be on ocular surface diseases. We would be sending the flyers out soon for the case to be sent. So I would, with that, we can close our session for today.
Last but not the least, we would like to thank Clarnet, Debolina and team for the technical support. And thank you to all the audience for making this session very interesting. And it was one of the, extended sessions, Karan, I'll say, in last 2 years where we have overshot the time. Okay, so thank you everyone. Good night. See you soon in the next session.
Bye.